Como todas las personas que estamos aquí, sabemos que una ciudadanía
Very well,
sana
just like everyone
y
else here, we
educada
know
no
that
solo
when your
ayuda a las
population is
mejores
healthy
sociedades,
and educated,
sino
that
que
can be
también,
is
y
something
por
that
otro lado,
improves a
acompaña al
society
capital humano
and also
y a
helps
la capacidad
human
de
capital
crecimiento de cada
continue to
país.
thrive and can help
Esto no es menor
increase
cuando empezamos a
growth
pensar
capacity for every
qué pasa en
country,
los
which is no matter
servicios
detail when we think
de
about
salud y
what
de
is happening with
educación.
healthcare
¿Qué
services and
sucede
education
cuando los
services.
miramos en
What
clave de
happens
calidad,
when
en
we
clave de
think about this in
escalamiento?
terms of
Ahí nos
quality and
encontramos con grandes retos en la
scalability? That is
región,
when we meet
particularmente
challenges
retos
in the region,
vinculados a los entornos
especially the
fiscales
ones having to
complejos
do with
y a desafíos
complex
vinculados
tax
a las
systems and
estructuras.
challenges that have to do
Ahora
with
bien,
the
estos
different
retos no solo
systems.
impactan a toda la
These
sociedad,
challenges have an
impactan
impact not only on all of society,
particularmente
but
al,
also and more
al
specifically
segundo tercio de la población de nuestra
two-thirds of
región,
the
que
population
está
of our
representado
region,
por minorías, por
represented by
poblaciones vulneradas,
minorities, by
y que tienen una capacidad y
disadvantaged
una
communities,
clave con la que tenemos que empezar a
where there
leerlos,
is
que
a
son
lot of
la
capacity that is
interseccionalidad,
unmet.
donde nos
It has
encontramos
to do with
con
intersectionality as
pueblos
well.
indígenas,
We
con
have indigenous
mujeres,
peoples,
con
we have
comunidad
women, we have the
LGTB+, con
LGBTQ
diferentes
plus
desafíos
community,
vinculados a estas
and a number of different challenges
interseccionalidades,
that are
desde
linked to
donde tenemos
these
que empezar a ver
intersectional
en clave del
components.
futuro,
And
en
this is
clave
where we
de
need
esos
to
problemas
start
que
looking
aún
for
no son
the
agenda,
future
como la
solutions
pobreza en la
and
vejez.
think about that in our
Todo
agendas,
esto
like
afecta y
the
todo
ones to
esto
address
tiene
poverty and
grandes
a
desafíos y retos, y es por eso que nos encontramos acá para
growing
pensar
and
cómo resolverlo, qué está
a
sucediendo,
population
qué
that
está
is growing
cambiando.
older. So
Tengo
this
el
is when
honor de
we
estar en este
can come
panel
together and talk about what
con
is happening and
diferentes
how
formadores
to
de
continue moving forward. I
políticas,
have a number of different
con
policy
académicos
makers who are with
referentes
us. We have
que no solamente nos van a compartir hoy
great scholars
experiencias,
and
sino
academics
también
with
que
us.
nos
They're
van a
going to share
acercar
experiences, but
soluciones
they're also going
posibles.
to provide
Les interesa en
potential solutions.
escucharlas, creo que es parte de lo que
I
queremos todas
believe
las
that the reason you're all
personas.
here is
Bien,
to be able
en
to
este
listen
camino
to
que tiene que ver
what these
también
can
con el
be.
ciclo de vida de las
As we
personas en
talk
nuestra
about the life
región,
cycle
vamos
for
a
people
empezar
in
con
our
la primera
region,
parte. La primera
we're going
parte
to
es
begin with the
el
first
desarrollo
part of our
infantil
panel,
temprano,
and that is
donde muchas
early
personas
childhood
piensan que es ahí
development.
donde
Many
tenemos que
individuals
invertir, porque
believe
los
that that is
estudios
where
nos dan
investments
cuenta
need to
de
go
que
because
el retorno de la
research shows
inversión es
that the
alto. De hecho, el
ROI
BID
in
y
that
otros
area is high.
multilaterales hace más
As
de
a matter of
25
fact, the
años
IDB and
invierten en
other
programas
MDBs for more
de
than 25
calidad
years
y
have
con
been
éxito.
investing in
Pero
programs to
el
enhance
desafío está a
quality
la hora de
and have done so
escalar. Y
successfully.
es ahí donde
But the challenge now is how to scale
esta
that
gran
up.
pregunta que queremos
That is
hacerte.
what
¿Qué
brings us to this
funciona?
major question,
¿Dónde? ¿Cómo? ¿Y de qué
Susanna,
manera?
that is, how does that
Thank
work,
you.
when and how?
And we have substantial evidence about what works for children 0 to 3 years. And we know what things are needed to help parents support their development and how to build the skills of caregivers who run parenting groups. Much of that evidence was produced in Latin America and the Caribbean. And the IDB played an important role in both supporting that and generating the evidence needed. So the other role that the IDB has been important in, though, is sharing that evidence across countries. So, for example, the parenting program that was developed in Jamaica at small scale was adapted in a trial in Colombia at moderate scale, and then that program informed the development of the Cuna Mas program in Peru. The pandemic has brought more attention again to inequities and the loss in learning as schools closed and services for families were reduced. But loss in development had always been occurring. Every year, large numbers of families and children do not get in need of early childhood programming, do not receive them. The result of this is that for children from disadvantaged families, there is a widening gap in development, which begins in infancy and by the time they reach primary school is large. It's therefore urgent that we move forward on scaling early childhood development programming. And one example of a moderately successful program is the Cuna Mas program in Peru. It was scaled up very quickly over 3 years to reach 70,000 vulnerable families from rural areas in Peru. Evaluation led by the IDB showed that despite the many implementation challenges, the program had modest benefits, but significant benefits for children's development. So how do we move forward for scaling? Well, the first thing is that we need commitment to sustainable investment in early childhood programming. Often there is commitment when programs start, but then over time, sometimes this drifts to other priorities. So we need to find a way of having sustainable budgets for early childhood. Another approach that has been used is to link early childhood programming to social protection or health systems. For example, in a trial in Colombia, the program was linked to the conditional cash transfer program, and the mother leaders from that program also delivered the child development visits. In some countries have evaluated looking at linking to health systems, such as Jamaica and Brazil. And what we find here, and the evidence is clear, that while health systems can be effective in identifying and reaching children in need, and in some cases may be able to deploy some staff to the program, for successful scaling through the health system, additional investment and resources are going to be essential. The largest scaling of ECD programming and parenting program in Latin America is the Criança Feliz program in Brazil. Beginning in 2016, by 2020, they're already reaching 500,000 families with home visits. And these families were beneficiaries of the Bolsa Familia cash transfer program. By 2021, that number had nearly reached 1.3 million. However, evaluation showed that in some regions, quality was not being achieved. And so in collaboration with the IDB and support from the Lego Foundation and collaborating with the University of Sao Paulo, the government began a process of retooling to improve quality. And some of the key elements were more structured guidance for home visitors, and an app to help them in delivery of the program, improve training, and improve systems for monitoring and support. I believe we have a lot to learn from the Brazil experience, and I'm really excited to hear more about it today.
Muchas gracias, Susan. Y seguimos también conversando sobre historias de éxito.
And we will continue to share success stories. This is a very special case because the best educational results were attained with limited resources, and it was the case that we will hear about next. So what happened? What happened? What was done differently? What were you able to do to export it from Brazil? Can it be exported or shared with the rest of the region? Good morning. First of all, I wanted to thank you for your kind invitation to be here with you. And I begin with your second question. I think, yes, it is possible. And I think that the experiences that are structured, that are systematized, that have generated evidence and that have shown some success, yes, I think that they can be replicated. Perhaps not as a given format, but within what is really behind, really guiding the experiences. In other words, the principles, the guidelines for success. And in the case of the experience in Ceará, there is evidence that, yes, it is possible because it is rather straightforward. You said that we, for example, don't have any special budget. We didn't have any new money, and it was that we saw what was beginning to happen, that we were getting better and better results, and that we were going to need more financing. So what we did receive allowed us to do better. And so it was a matter of talking to the people. And basically, it was the same people that had become part of a very inefficient cycle. And it was those same people that helped to change the whole story. And they continue to change it. So that is key. And what I would say is that these measures need to be rather straightforward, simple. There's nothing out of the ordinary. So that's something we learned from our experience. So, for example, leadership. In the case of the public administration, it's important to have some political leadership from the top so that the policies in the case of education will be given priority, and that there be political leadership so that those in charge of making sure that processes, that rules are respected. We need to have well-defined characteristics to make certain that we'll get a positive response on you will find in the media that there is a positive response as quality improves. Another important thing is to share the diagnosis. Make sure that that is tuned so as to establish priorities, and also to see who can do more, which is great. But in our case, there was a situation of inefficiency, and it was a serious situation. So we needed to set a few priorities so as to be able to elevate the status. We didn't want to be drawn into a cycle where we were investing a lot of energy, a lot of work, but getting nowhere. So we needed to be able to lift this effort up, reach higher levels, and we needed to set priorities. And I think that that gives us an important lapse of time so that the system can learn from an improvement in the whole organization, the whole sphere of action. We needed to move ahead in matters having to do with greater efficiency, greater collaboration, and also we needed to assure accountability. If we had a thermometer to measure that, it would be great, and you would see how important that is, that sense of responsibility, making certain that it's shared amongst the different players. Another thing is having an agenda, because it's not just our good intentions. It's not only good intentions that make things happen. You need to have an agenda, and it has to be substantive. So also making major investments in leadership in schools, other areas for leadership. And also I would mention investing in what we consider to be the two sources of leadership. That is the secretariats and the schools, where we need to make sure that the competencies are in place so that children can learn better. We need to focus on the classroom. Often I say that we have to get at the cutting edge. So we are right at the center, and we have to do things to make certain that they will be applied in the classroom, in the school, so that children can learn and have greater possibilities of having success in their life. Something else is evaluation and monitoring. Monitoring should be a shared responsibility. You cannot have any finger pointing, one party accusing another. Everyone has to share responsibility. So we're all here to help each other. And that is an absolute requirement. And then another thing I would like to mention is good communication. So you have persons that are involved. So we need to have good conversations. We need to have the support that is necessary to open up new horizons, to use resources or tools that are available, good experiences from elsewhere, and we need to benefit from those experiences too. Thank you, Marisola. Now, with Susana, you share what was said about collaboration, coordination, and that leads us to the next step, which is equally important. And that is something that in Latin America we see. The grandmothers always play a role, saying that health comes first. So first you have to be healthy. And in recent years, there has been major progress in terms of coverage, but we have to look at effectiveness, efficiency, and here something like 60% of preventable deaths have to do with quality. So how can we take that leap? How can we do that in terms of quality or addressing inefficiency and in those groups where the gaps are greater? In other words, the most vulnerable groups. Well, thank you. Thank you. And I think, Melina, that is a key consideration. Coverage of health services with no quality is wasting resources, and it's also affecting the health of the population. If you say that in 70% of the cases people die because they cannot reach the hospital or the health center, but if they did get there but received poor quality care, and that is unacceptable. Now, of course, that figure goes back to 2018, so some years ago. After that, we went through a pandemic. A lot of resources were invested in health. Almost 1% of GDP in some countries went to the health sector. So the question is, did things change? And I would say, yes, they did. They got worse. Health systems in Latin America and the Caribbean today are worse off than they were before the pandemic. And I can give you some examples beyond the tragedy of the deaths, all of the people that died because of COVID. All care was disrupted. It was affected. And quality indicators show that this is clearly the case. Coverage indicators, for example, for vaccination, DPT, diphtheria, pertussis. In Brazil, Peru, Argentina, there was a drop of 15 percentage points, right? And the average of the OECD, that number did not change. It remained at 94% in 2020, 2021. Now, coverage for screening, cancer screenings for uterine cancer, for breast cancer, it went down 40% in Mexico, Peru, and Chile. Now, also screening for high blood pressure, it was off by a high percentage. So that is a liability, and that will be a bill that will come due, especially in the most vulnerable population. But your question did not refer to the past. You asked about the future and what we can do. Resources are tight, that is true, but it's important to invest more in actions that improve quality and productivity of health services. The two things go hand in hand. Quality is not a luxury in only high-income countries, rich countries. No. Service without quality is a waste of money. So what can we do? First of all, the region needs a strong infrastructure of health data. We need to know about health governance, health data, to generate data on the use of our health infrastructure. How many beds do we have? What is the wait time? During the pandemic, that data was not gathered, but that's no longer the case. Also, we need to know how many people come into a hospital, get a hospital infection, how many people receive the right treatment, or are they getting antibiotics that are affecting them negative? And also, we need to know when a person is hospitalized, what happens? Did that person die in the hospital? Did they die 30 days after leaving the hospital? Did they die 1 year after leaving the hospital? Or did that person have to be re-hospitalized? So healthcare databases need to give us that information. We need to know what happened to these people. Why do we need aggregate data if we cannot identify what happens to these people? That requires investment, and it's a systemic investment having to do with the whole healthcare system. Latin America and the Caribbean needs to invest in health staff. In the OECD countries, the best predictor of COVID mortality, excess deaths during 2020 and 2021 was the size of the health care staff. And that is the best way to predict who was going to do better. So the correlation, one of the few times that I have seen such a highly correlated graph, is in this area. So now our recommendation is that the OECD healthcare system need an investment of 1.4% of GDP to be more resilient. And that is the average for OECD countries. Now, in Latin America, we have 40% of fewer physicians, 70% fewer nurses than the average for OECD. Of course, we know that this is expensive, that it's going to take time, and that we need to transform our health labor force. We need to remove barriers to teamwork. We need to improve initial education, ongoing education. Digital tools are also part of the solution. And the third point, quality has to be achieved by involving people. Care has to be person-centered. We need to measure results, experiences in health. We need to make certain that this is relevant to people. Now, PISA, that is a well-known OECD testing procedure. My colleagues have studied this for many years, but that changed the focus on education, going from teaching to learning. So it's not what I put into the education system, it's what I get out of the system that's important. And that is why in the OECD we're doing a health PISA, and that is the PARIS participation survey that is carried out in 25 countries. Unfortunately, no one in Latin America is participating. But it's really important to measure health results based on what people learn from their experience with the health sector. Now, no country can have a sustainable healthcare system without investing in prevention. The OECD average, 2.7% of health investment winds up in prevention. In Latin America and the Caribbean, we have several ticking time bombs, obesity, and also the aging ratio. That is going to become very costly for our health systems if things do not change. Now, if the pandemic taught us anything, it is that it can be expensive to invest in health, but not investing costs much, much more. And the same argument can apply to the quality of health services. Very impressive data, especially to have an overview. And here, Amanda, this is a major challenge, but we know that you will live up to it. So In terms of first steps, do you have a budget? We know it's important to invest, but also we have fiscal restrictions where we have to figure out how we can get good quality for our money. What can you say? I think that Federico basically covered the whole issue. But first of all, I would say that we have to understand the government, the public, the ministries of finance. And yes, we are going through a crisis in the health and education sectors because we just came through the pandemic, because we're facing new economic shocks. Also, the leaders in the region, everyone in the world is thinking, I have spent enough on COVID-19 and we're done with it. But that is not true. So these are high hopes, but they're not the reality. The truth is we are in the middle of a perfect storm of elements that are affecting the needs and the demand for health services. The population is aging. It is very urban with high access, with high risk factors, that is smoking, obesity, malnutrition, also with volatile income and markets, and with inflation. So health systems are also a victim of their own success in that they built up a health system with more access to technologies, procedures that lengthen the lifespan, but at the same time, our possibility of caring for the elderly, for example, have not evolved to take adequate care of the elderly that are living longer, but with higher vulnerabilities and greater needs. We talked about neglect of public health, and for decades, the public expenditure on health has leveled off as a percentage of GDP in most countries. And the result is a very high out-of-pocket payment for a large part of the population. So what we see is that often families wind up in poverty because of having to pay out-of-pocket costs in case of a disease. And then we, in Latin America and the Caribbean, see that there was a very high excess death rate. So for every 100,000, there was 400 excess deaths, outpaced only by Russia, a country at war. So I think that the need to reform health is crystal clear. So, Minister, or as minister, I will hire Federico. No, we need to include the economic and financial perspective in our reforms. No one really likes economists, even though we're here at this meeting. But the business of economists is to assure maximum results. Health with equity, all within a budgetary limit, which is a reality, and that limit is a very stringent one. But without looking at fiscal consolidation, we can say that we are in a world where we're rationalizing expenditure and care. We are often following skin color, ability to pay, things that are unfair and that lead to unnecessary deaths. So I want my economists to get to work. And I think that we have made good progress in doing an economic evaluation of health technologies in several countries of the region, prioritizing expenditure, looking at the value of an intervention or of a medicine and the price that I have to pay for that new technology. So that's very important in Brazil, Colombia, Chile, Ecuador. They made major strides. But this is only one part of the expenditure. The rest of the spending on policies, on interventions, also has to be analyzed. And the question is, what do we do with new innovative technologies? Should we buy the new vaccine against obesity? Yes or no? Should we throw away our COVID-19 vaccines, or should we use bivalent vaccines, new vaccines, perhaps buying those? And I think that my specialists are going to be looking at reforming the service and also providing assurance and coming up with effective ways to deal with vendor payments. And all of this has to be examined closely to see if they work or not. And as a minister, I have to be willing to listen to bad news to change my procedures. Also, we need to do reforms looking at the transaction cost of everything we do. Especially, you have to understand the functionality, the operations of current systems. Can you get rid of everything? And you could understand that because people are frustrated when they look at how things are going. But they still have to plan carefully to avoid any disruption in the service that can literally kill. All systems have things that are good and things that are bad. We have to protect what is good. For example, in the Colombian system, there is emphasis on primary health care. That is the case in Costa Rica and in Brazil. Now, I know that the medical profession really is not fond of us as economists, but we have to understand that we are part of a whole wave of needs and demands, and this can be part of an economic instability if this is not carefully addressed, and it's macro-critical in terms of health and well-being. Thank you. And also, we have to look at technology, right? In recent conversations, we see how important this is. And here I'm going to ask everyone, not only you, but also I share this challenge with others. It may be discussed on social media. They are connected to our meeting. And also there's some streaming services. So I would like the audience to participate too. So what should the IDB and other multilateral organizations be doing to change, to improve on this agenda? What recommendations would you make? And here the challenge is in 140 characters as a tweet. Please be brief, and we will begin with Maria Isolda. Maria Isolda, what would your short comment be? Well, here I am looking as someone that is part of a team working with the Ministry of Education. But I think that we need to integrate, we need to support subnational organizations and combine that with a more coordinated policy, a policy that is better connected to well-defined objectives and goals. That would give us the possibility so that the IDB can act in areas where it is present to strengthen that agenda. I'm thinking, for example, of those places, the places that are the major challenges that suffer from greater inequalities. I think that that would be great because it motivates engagement, and also it creates a perspective for continuity. Great. That was more a Facebook comment than a tweet, but please, Susan, what would you say that international organizations need to do differently so as to support?
The issue of quality and achieving quality at scale. Monitoring program implementation and support for staff delivering has been a challenge in many countries. And it seems to me that the IDB is uniquely placed to support quality in several ways. Firstly, through analysis of social protection and health systems and seeing how we can most efficiently integrate or deliver early childhood, either through those systems or maybe it needs to be done separately. Secondly, when a program is going to start, it shouldn't start until it's clear what decisions have been taken about how to sustain quality, what preparation has been done for that, so that as the program starts, that is already getting attention. And finally, I think the IDB should be, we need innovative strategies. We need strategies that are efficient for staff time. And the IDB could be a supporter of innovation in this area. And possibly also in terms of electronic systems and digital solutions, so that we can really begin to achieve scale in ECD.
Excelente. Ferdinando.
Wonderful. So, would you care to comment? I can give you 2 tweets and 1 hashtag. The first is, more than investing in small pilots that are very localized, IDB should help countries overcome the systemic gaps, the systemic weaknesses in terms of productivity of care. And then the second tweet is the quality of health care services. It is not a luxury of rich countries. It's a basic requirement. And the hashtag is health with quality, no excuses. I love that. And Amanda? Amanda? Federico should have been last. Well, the IDB is a bank of knowledge. That is its value added. So that knowledge has to be applied to an investment at scale in the health sector to improve results and save lives. Wonderful. You are the queen of Twitter. I love that. And now to wrap up. As a takeaway message of this panel, can we think of efficiency and quality? Can we think at scale, thinking of impact? And because we have policy makers, we have academicians, we have history changers like you. On my way here, I had to tell my 1-year-old child that I was about to travel, and I explained to him that I was going to spend some time with people that were designing his future. So thank you. Thank you for being part of this effort. Thank you for listening to us. And now we're going to hear from Mariano Bosch, who will be talking about the population and social protection. So thank you. Thank you for being with us. And we will look at the tweets to see what impact we have had.